Can we move on to the next session? And I invite Dr. Jyotidev Keshav there, the Scientific Chair of Diabetes India 2022, and Professor Jahangir Chowdhury to take over the next session, please. Is Dr. Jyotidev there? Dr. Jahangir, please take over.
Yeah, I'm here. I'm Professor Jahangir Chowdhury from Bangladesh. It's a great pride and privilege for me to be a chairperson of this session. I am giving thanks to the Diabetes India for giving the opportunity to be here. I'm also very grateful to attend here as the partner of one of the great men, Dr. Jyotidev Keshav. He's also with me as a chairperson, possibly. So I'm requesting if Jyotidev Keshav is here, then I'll request to talk. If not, then I will just
here because they are asking for it. Here, you can do from here.
Keshav is there. Keshav is there.
Bansi, please continue.
This is Dr. Sanjeevi speaking. Bansi.
Yes.
Is there any possibility that I can go first?
Yes, he'll join soon.
Yes, Keshav is there.
Keshav is there. Dr. CB Sanjeevi is asking if Dr. Akhtar had not joined, then he can.
Oh, yeah.
That is what is required.
Oh, yeah. Yes. Then
Akhtar is not there. We can request.
Then I am requesting Dr. CB Sanjeevi from Sweden to deliver his.
Please introduce Dr. Sanjeevi and then
Professor CB Sanjeevi is Vice Chancellor of Sri Shathya Sai Institute of Higher Learning in Puttparthi and Professor and Senior Scientist at the Department of Medicine, Karolinska Institute in Stockholm. He is also Senior Advisor to the Innovation Office of Karolinska Institute. He heads the Diabetes Immunology Research Group at the Center for Molecular Medicine at Karolinska University Hospital at Stockholm. He has won many awards. The recent one was Prabhashi Bharatiya Shaman Award for 2017, which he received from the President of India, Sri Pranab Mukherjee. It is the highest award given to a person of Indian origin by the government of India for his excellence in the field of medicine. He has edited series of 5 volumes of the Annals of New York Academy of Sciences entitled Immunology of Diabetes. In addition, Dr. Sanjeevi serves in the editorial board of several journals and has extensively published in peer-reviewed medical journals. I would like to request Dr. Sanjeeva for his presentation.
Thank you very much, Professor Jahangir, and thank you very much, Dr. Jyotidev, for being a chairman of this session. Let me get the technical thing correct here. I just need to get my slides up. It's already open. How do I get it? I say share. Yes. I'm not getting my slides. I've kept it open in my desktop. How do I get it on the screen? I don't usually use Zoom so much. Can somebody help?
Those are your slides. You can just open those slides from there. Just click on it.
I have opened the slide.
Is it visible to you?
Is it visible to you?
Yeah.
Perfect.
Yes, we are getting it.
Thank you very much. Thank you, Bansi, for giving me the opportunity to talk. What you had invited me to give a talk is this particular topic. What is there in the program is another topic. So this is the most interesting part, which I thought I will share with all of you. I had access to retrieve a lot of information regarding the discovery of insulin and the Nobel Prize that is being was awarded to Banting and McLeod. So How do I move this? The slide is... the Nobel Prize Committee for Physiology and Medicine is working from the Karolinska Institute in Stockholm. And this is the main entrance of the Karolinska Institute. Immediately to the left, once you enter the main entrance, is the Nobel Forum, where the Nobel Committee meets to decide the prize. And what you see on the right is the building called Aula Medica, where the Nobel lectures are held on 7th of December every year. So the building called Nobel Forum is immediately to the left as soon as you enter Karolinska Institute. And it has a long foyer. At the end of the foyer is a very big lecture room where the Nobel Prizes are announced. And you have the bust of Alfred Nobel outside this building. And what you see as the assembly hall is the place where the Nobel Committee decides the prize. And the secretary of the Nobel Committee comes down from this first floor assembly hall to the Wallenberg Salen, which is the lecture room downstairs below the assembly hall, to announce the prize. So this is the tradition that happens. And this announcement is usually made on the first Monday of October every year. And the first prize that is announced is the Medicine and Physiology Prize. And to give you a little bit of a background about Alfred Nobel, before I go to talk about Banting and MacLeod and how they got the prize, Alfred Nobel was born in Stockholm in 1833 on October 21. And this is the house from which, in which he was born, which is looking pretty decent, I would say, as of 1833 standard. And Alfred Nobel comes from a very Nobel family. And his father is Emanuel Nobel, who is a very big engineer himself. And his mother is Henrietta Nobel. And they were living in Stockholm. And what had happened is that Alfred Nobel had taken over a lot of importance and the inspiration from his father in terms of invention, in terms of discoveries. And Alfred Nobel was the first one to discover the dynamite. And this is the patent that was awarded to Alfred Nobel in 1863 for the discovery of dynamite, in which nitroglycerin was mixed with kieselguhr. And dynamite became extremely famous for a variety of reasons. Not only it is used in blasting rocks and things like that in order to lay roads or build constructions, but a lot of activities were done with dynamite that were really not so peaceful. So it had lost a lot of charm for its discovery, and because it was all used for wrong reasons. So this had led Alfred Nobel to feel terribly bad that his discovery is being used for destructive purposes, not for constructive purposes. So in 1895, on November 27, he wrote a will. And by that time, he had become an extremely rich man. At the current standards, if you apply, in 1895, he would have been the world's richest person at that time. So in this 4-page bill, which constitutes the backbone for all the Nobel Prize that is awarded, he has given clear instructions on what are all the things that the Nobel Committee has to do in order to select the laureates and give the prize. An entire wealth of Alfred Nobel had been put in the Nobel Foundation, which uses the interest from that corpus in order to give away the prizes, and also do a lot of Nobel related activities in terms of running symposiums and things like that. So the title Physiology or Medicine was chosen by Alfred Nobel. And at that time, he had given 5 different prizes. And one of them is peace, which is to be decided by the Norwegian Parliament. The other prizes are physics, chemistry, and literature. And later, the economics was added, not from the Nobel will, but from the corpus that was created by the Central Bank of Sweden. So Axel Key was an important person who was responsible for creating this particular Nobel Prize for Medicine at Karolinska Institute based on the will of Alfred Nobel. And Jons Johansson, who was the chair of the Nobel Committee, and Göran Eliasson was the secretary of the Nobel Committee. And Göran Eliasson has served as the longest period of time as the secretary of the Nobel Prize Committee. And during his term was a time when lots of important discoveries were announced, including that of Banting and MacLeod. So one of the important aspects in Nobel will is that no prize could be shared by people more than 3 persons. So in no case may a prize be divided between more than 3 persons. That's why either we can give it to 1 or 2 or maximum 3 people or not more, is something that is based out of the will that Alfred Nobel had written. And one of the important things that he had written also is that the discovery should have been made in the preceding year. But it is really unlikely to identify a particular discovery and its effectiveness within a period of 12 months. And the only one prize that was awarded within 1 year of the discovery is the discovery of insulin. So that's the only prize that qualifies actually for this particular aspect of the will, whereas the Nobel Committee interprets this preceding year as preceding years, so that nowadays any discovery that is made, it takes at least 20-25 years before the Nobel Prize is awarded for the discovery. So this is one of the things that insulin discovery is the one that fits the bill very nicely as far as the will of Alfred Nobel is concerned. And of course, it has to be physiology or medicine. That's why prizes not necessarily have to be clinical medicine. That could be basic biology also that has an important implication in medicine. So coming to Nobel Prize for Banting and MacLeod, which was awarded to both of them in 1923, there have been a lot of interesting behind the scene activities that have happened. And I'm going to tell you some of those things because I had gone and sought information from the archives of the Nobel Foundation that is sitting at the Karolinska Institute. And I also wrote an article in Diabetologia in News and Views column in 2001 when we were celebrating 100 years of Nobel Prize. So there is a lot of interesting information that I'll be sharing in the following slides. So Banting and MacLeod was given the Nobel Prize in 1923 for the discovery of insulin. And the discovery was published in 1922. The nomination of the prize was made in 1923. As you all know, the deadline for nomination for Nobel Prize is 31st of January for that year. If you take 2022, January 31 is the deadline for the nomination for 2022. Whereas in this particular year, 1923 prize, the deadline for nomination was January 31, 1923. And in this particular year, you can see how the nominations had happened. And in Nobel Archive, you cannot access any information in the Nobel Archive in the last 50 years. Anything longer than 50 years, we can get access to the Nobel Archives, do research and publish it. So the choice of a combination had been debated by a lot of people. Banting had shared the prize with, the discovery was shared between MacLeod and Banting. But what happened was that Banting received 50% of the money, and he shared 50% of that money with Charles Best, and he felt Charles Best should have been included. And I can tell you why Charles Best was not included in the nomination for the 1923 prize. So this is the Nobel certificate that is given to the award winner along with the Nobel medal. And this is the certificate that was given in 1923 to Banting and MacLeod. Interestingly, on that particular year, both Banting and MacLeod did not come to Stockholm to receive the prize. The prize was actually sent to them through the Swedish ambassador to Canada and Swedish ambassador to United Kingdom. So this is how the Nobel Frederick Banting and John MacLeod's Nobel Award looks like. And when you look at the discovery, you will see that Banting was featured on the cover of the Time magazine in 1923. Then this is the house where Banting had worked, lived, and also did the discovery. And there is an eternal flame outside his house that's burning in memory of him. And you can see that Frederick Banting, his statue is there adorning the lawns of his house. And if you can see, this is the study. This is the place where he had been treating patients with insulin that he had made. And these are all the facts that had been put in the Nobel Foundation, where the Frederick Banting, Nobel Prize in Physiology Medicine for 1923. He was born in Alliston, Canada, and he died in 1941 in Newfoundland, Canada. So affiliation at the time of award was to the University of Toronto in Canada. And the prize motivation was discovery of insulin. And he shared half the prize that was awarded to the discovery, the other half going to MacLeod. So what is the interesting background information? How did Banting and MacLeod win the prize? This is something that will also tell you how the Novo Nordisk was born at that time. So few years before that, in 1920, a gentleman, Danish gentleman by name August Krug won the Nobel Prize for Medicine. And his prize was awarded for the discovery of capillary motor regulating mechanism. And he had done a lot of work in 1910. And this work clearly demonstrated the absorption of oxygen and elimination of carbon dioxide in the lungs takes place by diffusion and diffusion alone. At that time, this particular knowledge was not available, and he was the first one to enunciate that. So he had published this work subsequently in 1918 in Danish and 1919 in English, and he was awarded the prize in 1920. But he is the person who was instrumental in making the nomination for Banting and MacLeod that helped him get the prize. And what happened is what you are going to see in the next slides. So August Krug had a wife by name Marie Krug. And Marie Krug in 1921 developed diabetes. At that time, the diagnosis was called as maturity onset diabetes. So August Krug was invited to the United States to give a lecture tour because he was a Nobel laureate and very famous. And he took his wife alongside. So when he went to Boston, he had a private dinner. And Marie Krug was told by the renowned American diabetologist whom you all know, Elliot Jocelyn, in whose name we have the Jocelyn Diabetes Center. So Jocelyn, August Krug and Marie Krug had a dinner, and during that conversation, August Krug mentioned about his wife's diabetes. This is when Elliot Jocelyn informed him to go and make a visit to Toronto, where John MacLeod and his group of scientists have discovered insulin, which might be extremely beneficial for his wife. So August Krug made some changes to his plan. He went from Boston to Toronto, and he met with MacLeod and was his guest for some days. And he visited the laboratory, met with Banting, and discussed all the discovery. So he was extremely convinced about the insulin that was made that could cure diabetes and bring down blood glucose. And what Krug did was he obtained a license from Banting and MacLeod, and which allowed him to use the protocol for insulin purification that they had developed. So he came back to Denmark. He started the production of insulin on his return to Copenhagen. And the first patient was treated as early as March 13, 1923. So what he did was, the doctor in Denmark was Hagedorn, who was the one who was treating Marie Krug for her diabetes. So Hagedorn was interested in manufacturing insulin in Denmark with the license obtained. And Krug then found the Nordic Insulin Laboratory where insulin was manufactured, and the Nordisk Insulin Foundation. So these two items, or these two companies, later transformed into Novo Nordisk, a Novo Nordisk Foundation, which you are all very familiar now. So Marie Krug was treated with insulin that was made in Denmark with the license from Banting, and she died in 1943 due to cancer. But all these years she was treated with insulin, and her children did not know that she had diabetes. You can imagine how effective this particular discovery had been in keeping Marie Krug alive and well. So this is very interesting. So Krug was very impressed with the discovery. So what he did was he was the one who nominated Banting and MacLeod for the Nobel Prize by January 31, 1923. So it is very interesting that Banting and MacLeod were the ones who were nominated by August Krug. But if you look at the nominations that were received in 1923, Banting was also nominated by Kreil from Cleveland, Benedict from Austin, in addition to August Krug. Whereas MacLeod in 1923 was also nominated for the discovery of insulin by Stewart in Cleveland and August Krug. So August Krug had actually nominated both the people, whereas the other people who had nominated Banting did not nominate MacLeod, and vice versa. So this was very important, mainly because if a Nobel laureate is going to make a nomination, that carries quite a big weight in the Nobel Committee, where the nomination received by the Nobel laureate will be considered as good as a critique out of the one critique for the nomination. So this is what Alfred Krug wrote in proposing Banting and MacLeod. And he writes, with the information which I personally have obtained in Toronto and which also, although less clearly so, emerges from the published work, one may conclude that the credit for the idea behind the work which led to the discovery undoubtedly goes to Banting, who is a young, apparently very talented man. However, he would definitely not have been able to carry out the investigation, which from the start and during all stages have been supervised by MacLeod. So Alfred Krug clearly identifies Banting and MacLeod as the important players for discovery of insulin, and both of them should be awarded the Nobel Prize for Medicine for the year 1923. So in 1923, he followed up with another letter. As you understand from my discourse, it's my opinion that the discovery of insulin is extraordinary, both theoretical and practical importance, and it hardly surprises you that I intend to submit a nomination for the Nobel Prize for award to Banting and MacLeod. So this is how he wrote to the secretary of the Nobel Prize Committee, who was called as Göran Liljestrand. So subsequently in 1924, August Krug writes to Göran Liljestrand again, saying that it was really a fantastic nomination and the prize, but he sees that there have been a lot of criticisms that Charles Best was not included in the prize. So he says, I understand that the prize to Banting and MacLeod, ignoring other co-authors, has not been met with absolute consent on the other side of the Atlantic Ocean, and that especially Banting is offended by the fact that Best was not included. So you will realize why Best did not get the prize very soon. And however, I'm convinced that the correct choice is made is what Krug is talking about in terms of nominating Banting and MacLeod. So as you all know, if you are not nominated, you cannot be considered for the prize. So if you ask the question, was Charles Best nominated? He was not nominated in the year 1923. Nobody else can add his name subsequently to the nominations at a later time because the nominations close on 31st of January. So it becomes reasonable that Krug's nomination had some impact on the award of the prize to Banting and MacLeod because he was already a Nobel laureate. So when you look at these things in detail, you will realize why was MacLeod included and why was not Charles Best. As I said, Charles Best was not nominated, so he could not have been included, so he could not have won the prize in 1923. But are there other candidates who could have as well got the prize? Because some people felt that this prize was too rushed. The discovery was in 1922 and the award of prize was in 1923. So if you look at other things, there is a very nice book written by a guy called Bliss in 1982, where he finds that other people who should have deserved the prize are Nicholas Paulescu, Joseph von Mering, Oskar Minkowski, would have been as worthy as of Banting and MacLeod. And this is also written by Bliss after he had interviewed Rolf Luft, who is a very senior professor and also chairman of the Nobel Prize Committee at that time. And this interview was made with Rolf Luft sometime in 1971. So there was some additional information. If you look at it, Paulescu was never nominated, so he couldn't have got the prize. Kollip and Best were nominated, Kollip in 1928 and Charles Best in 1950, but for a different thing, not for insulin. Von Mering was nominated, but only in 1902 and 1906, and while Minkowski was nominated in 1902, 1906, 12 and 14, as well as 24 and 25. As you can see in 1923, if only Minkowski would have been nominated, he would have been the third candidate to have been awarded the prize for discovery of insulin, because Minkowski has also done quite a bit of work in insulin. So all these things put together, according to the statutes of the Nobel Foundation, none of these candidates could have received the prize in 1923 because no one else had been nominated other than Banting and MacLeod. So perhaps the committee said the choice made was the best possible choice, looking at the number of nominations that had received for that particular year. Still, the criticism remains, why did you rush it and give it in 1923? If you could have waited a little longer, maybe other people could have been nominated as well to have received the prize. But this was the decision that was made based on the nomination by Alfred Krug, and that is the one that stands now as the only prize given by the Nobel Prize Committee for a discovery that was made within 12 months of the award of the prize. So this is the lecture written in the form of a book that Frederick Banting made, and he had even signed it and given it to his father and mother about the Nobel lecture that he gave. Since he did not come and receive the prize in person, this lecture happened at a subsequent time with this bulletin or a manuscript that he had wrote about his talk for the Nobel lecture. And you can see in this picture, you can see Charles Best and the dog that in which they did all the experiments that made them to make the discovery for insulin. So Charles Best was a young PhD student at that time. A Nobel committee might not consider it favorably if a PhD student is a part of the discovery, because PhD students never actually do anything by themselves where they follow the guidelines of the supervisor. So if you can see the important motto of Alfred Nobel is the discovery should be given for discovery or invention that should be of greatest benefit to humankind. So this is an important aspect that one needs to consider. So this is the first Nobel Award ceremony in 1901 that was held in Stockholm. This is an old black and white picture. And the host of this particular Nobel Prize ceremony is the King of Sweden, always, all these years, all the time. So this is one of the biggest functions in Sweden. And this is the dinner that anyone would like to go and attend and participate, the Nobel Prize dinner. So what happened to Charles Best? Is there something that, has he ever been nominated? I said he was nominated in 1950. But if you look at some of the other nominations, he had been nominated by 11 different nominees, and 3 of them in the 1950, 3 of them in 1951, 1 in 1952, and 4 of them in 1953. So he has been nominated for every year over a period of 4 years. Charles Best was born in 1899 and he died in 1978. And he was a professor of physiology. And he himself had nominated George Minot and George Whipple. And he nominated Bernardo Albert Husse for the Nobel Prize. And Bernardo Albert Husse from Argentina had also nominated Charles Best himself, as the nominations are sent to some of the senior professors all around the world. And they are the ones who can do the nomination, in addition to the Nobel laureates who can nominate directly to the Nobel Prize Committee. So Charles Best was nominated several times, but in none of those years, he was successful in receiving the prize. So he could not get it. And if you look at the distribution of people who had nominated Charles Best across the world, we have had people from Canada, people from Argentina, people from Paraguay, people from Britain, Switzerland, Austria, several countries. People had nominated Charles Best, and unfortunately, he was not able to win the prize because at that time the prize had gone to somebody else. So, what we learn from the history of the Nobel Prize? So, knowledge in society is something that we all should know. Societies that have invested in research-based knowledge have prospered. To achieve such a knowledge, it should not be looked upon as a cost, but as an investment. So, creating new knowledge is important, and investment in creating new knowledge is extremely important. Of course, the other opposite side is if you don't like research-based knowledge, one should try ignorance, which is what is prevalent nowadays with the knowledge that people get from Google and other online sources. So this is something that is very important for us to know, that the award of Nobel Prize for Banting and MacLeod is an award that is well deserved by both of them. Charles Best could not have been given the award simply because he was not nominated at that time. And subsequently, when he was not the prize, somebody else got the prize. So that is the bad luck. And Charles Best had written several letters to Rolf Luth, who is a professor at Cardiovascular Institute, showed me some of those letters where Charles Best felt very bitter that he had been left out of the prize and he has not given the prize, been given the prize. But to be honest, when I had several discussions with Rolf Luth when he was alive, his opinion was that Charles Best did not deserve the prize. So that was his opinion because he was the chairman of the Nobel Prize Committee at that time. And you all know Rolf Luth was a person who was the first person in the world to discover mitochondrial diabetes. At that time, it was called as Luft disease, named after Rolf Luth. So I thank you very much for your attention. These are some of the contributions I had made in terms of books for immunology of diabetes. If any of you are interested in following some of the recent advances in diabetes, you can visit the Facebook page Thoughts on Diabetes, where I put a lot of new pieces of information that is becoming available in the world of diabetes. You can look at the references, sometimes the PDF file, etc. With this, I conclude my talk. I sincerely thank Bansi for inviting me to give a talk, and I thank our chairpersons for the introduction and the kind listening. Thank you. Thank you, Jyoti Dev. And bye.
It was an excellent one. It was an excellent lecture, Dr. C.B. Sanjavini. And it was as good as listening to a screenplay of a classic movie. We really enjoyed it. And we are having a discussion at the end of the other two lectures.
Can I make a small request? I have to go for another talk in the university right now. Is it okay? I can take few quick questions now. Is it possible?
Yeah, sure. We will have 1 or 2 minutes for some questions. Is it okay, Dr. Jahangir? Yeah, fine. So let me ask you a very simple question. So you have said that according to the rules of the Nobel Prize, you can give the Nobel Prize only to 3 individuals at a time,
right,
and not more than 3.
Yes.
And when you look at the discoveries, the innovations in the current era, most of these innovations are from a team. And this team could be more than 3 or more than 4 or more than 5. And your lecture is pertinent to the theme of our Diabetes India, and that is 100 years of insulin discovery. And after 100 years of insulin discovery, when more and more people are involved in a single innovation, how can you resolve this 3 individual?
If you look at it, this is the insulin that was used for treatment of diabetes.
Yes.
Okay. But insulin has been awarded Nobel Prize on 3 different occasions. The first person to sequence insulin, the peptide sequence of insulin, was made by Sanger at the and which now becomes Sanger Center in Cambridge. And Sanger got the prize, I don't remember, somewhere in the 1950s for the first person to sequence insulin. So there was one more person who was awarded the Nobel Prize for doing a radioimmunoassay to detect the insulin levels inside the body at that time. So there had been different discoveries, but this particular one was instrumental, phenomenal at that time because there's nothing else available for treating diabetes. So it was so important in terms of managing a disease, whereas otherwise the people would have died. So there's nothing else available at that time. So that was the importance that got. But if you look at the question, as far as the medicine prize is concerned, we never give the prize to an organization, unlike the Peace Prize, okay, where it is given to WHO or given to World Food Organization, etc. It has to be for a discovery or invention. That's very important. So when we make this discovery, we just go back in time to find out who was the first person to do it. Okay, that makes it very important. If the discovery were made by 2 different people, more or less at the same time with few months apart, that's okay, because any discovery needs to be validated and confirmed by a second person. Then it's not actually a well-validated discovery. So if you look through the history, you've always gone back to the first person who did it. And subsequent people might have developed it or might have improvised it. That doesn't make them an inventor or a discoverer. So this is the 2 words that are important when we want to nominate anybody for the Nobel Prize. So when I make the nominations myself, I have to screen the people very carefully to ensure that are they the first ones to do it? Is that a theme or a title topic that had been extremely beneficial to the mankind? These are some of the things that we have to look at. So one cannot nominate anybody. They all become a dummy nomination because I'll have to argue and justify that the nomination is mainly for discovery and insulin. That motivation is what is important here. So we have to go back and find who is the first one. So there has to be only 1 or 2 people in the first one.
Yeah. Well. Thank you very much. More than 8,500 doctors are listening to us. They are listening in the virtual platform, and more than 1,000 doctors are there at Goa for face-to-face meetings. So thank you very much, Dr. Sanjivani, for joining us.
Thank you very much, Mr. Jyoti. I wish I could have interacted with all of them. Thank you for this question and thank you for your time. Bye now. Bye.
Good day. Thank you. Over to Dr. Jahangir, please. Unmute, sir. Unmute, sir.
Is Dr. Akhtar Hussain from Norway is available?
I am also looking for him. He is not here. Then we will move on to the next one then.
And then Jaco Tomihel Shaukat from Finland.
Yes.
Yes. Jaakko Tuomihieto from Finland, MD, MA, PhD, FRCP, Professor Emeritus, Public Health, University of Helsinki, Finland, visiting senior scientist, Finnish Institute for Health and Welfare, Helsinki, Finland, and visiting professor, National Public Health Institute, Madrid, Spain. And his subject is cardiovascular risk factor management and prognosis in patient with dysglycemia. I'm requesting Dr. Jaakko Tuomihieto.
So thank you very much for the introduction, and thanks for Dr. Banshi for the invitation to join this meeting once again. I have enjoyed the face-to-face meetings also. I have enjoyed a lot to be in India, but now from Finland I will present my lecture here. Now I need to find this one. No? Okay. So it's not, just a second, not in the beginning. Here we go. So my lecture is about the cardiovascular risk management in people with dysglycemia. Here is my conflict of interest. Now, we know that people with diabetes have an elevated risk of cardiovascular disease, whether it's a cardiac or cerebrovascular or other vascular, that is a peripheral vascular disease. So very clearly, diabetes is an important contributor to cardiovascular burden in a global sense. Now, the question then is, what can we do to reduce this burden? And what I'm going to present is quite a lot of information generated by the European Society of Cardiology and the European Association for the Study of Diabetes. And this is an update. I was working in the 2009 and 2013 recommendations, and this is the latest one, which I was not part, but very much involved in the discussions. Now, this analysis of vascular risk in diabetic individuals in the three different categories: very high risk, if there is already some target organ damage, or three or more major risk factors, or type 1 diabetes over 20 years duration. And a high risk is people with diabetes duration over 10 years without target organ damage. And a moderate risk is typically a young person with type 1 diabetes or type 2 diabetes without any other risk factors. Now, recommendations in this document are based on a classification of ranking the evidence, and the class 1 and class 2 are those where the evidence is sufficient to make a clear recommendation. Now, the microalbuminuria should be measured in people with diabetes. ECG should be also taken in people with diabetes, especially if there is hypertension or suspected cardiovascular disease. and also the carotid or femoral plaque burden with the ultrasonography should be considered in asymptomatic patients with diabetes. And when it comes to advice for lifestyle, smoking cessation is recommended for all people with diabetes and pre-diabetes. And actually, I would point out that these recommendations, they very much also go to pre-diabetes, not only to diabetes. The lifestyle intervention is recommended to prevent conversion from pre-diabetes to type 2 diabetes, which is known to be very effective, and reduce calorie intake if people are obese. Now, when it comes to physical activity, the usual recommendation is 150 minutes a week at least for prevention and control of diabetes. And then the evidence is accumulating that the so-called Mediterranean diet, which is rich in polyunsaturated and monounsaturated fats, should be considered to reduce cardiovascular events. And the multivitamin supplementation is not recommended. There is no evidence that the vitamin supplementation reduces the risk of diabetes or risk of cardiovascular events in people with diabetes. When it comes to the targets, the main thing is hemoglobin A1C, less than 7%. This is to decrease microvascular complications, which is well known from several studies. But we know now that A1C targets should be individualized according to duration, comorbidities, and age, so that it may be higher in some individuals, especially with the comorbidities. An important point is to try to avoid hypoglycemia, because it's known from glycemia as one of the factors resulting in cardiovascular disease in diabetic individuals. And then the self-monitoring of blood glucose or continuous glucose monitoring should be considered to facilitate the optimal glycemic control. And also, when we think of macrovascular complications, again, the A1C target is recommended. When it comes to treatment with antidiabetic and antihypertensive drugs is recommended if the blood pressure is over 140/90, and then the goal is to reduce systolic pressure to less than 130 if tolerated, but not less than 120. There is no evidence that less than 120 would be beneficial. Actually, it may be harmful. And in the older people, a little bit more flexible goal of systolic pressure should be considered. And again, diastolic target should be 80 or less, but not below 70. And for cerebrovascular event, especially important is to consider systolic pressure less than 130. Now, lifestyle changes for treatment of hypertension are important. It's convincing evidence we have today that the physical activity, reducing overweight, restrict alcohol intake, restrict sodium intake, and to increase fruits and vegetables and low-fat dairy products are useful to lower blood pressure. And then when it comes to treatment choices, the RAS blocker is recommended in diabetes, especially if there is evidence of albuminuria or left ventricular hypertrophy. And quite often we need a RAS blocker and then calcium channel blocker, which is neutral regarding glycemia, or thiazide diuretic should be considered, although thiazide diuretic may have some unfavorable effect on glucose levels, but once people already have a diabetes, the effect is much smaller. Now, in people with pre-diabetes, also RAS blockers should be preferred to beta blockers and diuretics, because these latter drugs may increase the risk of progression to diabetes. And of course, today there is a lot of discussion also the SGLT2 inhibitor that may also lower blood pressure. And home blood pressure monitoring is nowadays recommended, and also in many patients it would be useful to understand the 24-hour blood pressure patterns, especially the nighttime blood pressure, in order to adjust the antihypertensive treatment, which usually is now recommended to take late in the evening before going to bed. There is an evidence that taking antihypertensive drugs at the bedtime reduces cardiovascular events more than if you take the drug in the morning. Concerning a lipid management with the moderate risk of CVD event, the LDL cholesterol target is 2.6 millimoles, and in those with a high risk, 1.8, or at least 50% reduction in LDL. And in those with a very high risk, LDL target should be even lower, 1.6, and again, at least 50% reduction. And in individuals with type 2 diabetes, the non-HDL target, which is today very much used in the clinical practice in Europe at least, there is the goal to have a less than 2.2 millimoles in very high risk and 2.6 in a high risk patients. And statins, of course, are considered the first choice treatment for lipid lowering. And again, the administration of statins is depending on the CVD risk profile. And if LDL cholesterol target is not reached, then ezetimibe is recommended. And also with a very high risk CVD patients, and if statins are not tolerated or effective, also PCSK9 inhibitor is recommended. And again, the lifestyle intervention with the weight reduction and reducing fat intake are recommended. And also the fibrates may be considered if a patient has a very low HDL cholesterol and high triglyceride levels. And always it is important to intensify statin therapy before introducing the combination therapy. Then it comes to aspirin. It is recommended in the very high and high risk patients with diabetes, even for primary prevention. And in patients with moderate CVD risk, primary prevention use of aspirin is not recommended. And when aspirin is used, one should consider to use proton pump inhibitors in order to prevent bleeding, GI bleeding. Now, these individual recommendations are important, but we have to remember that the combination management is the key. We have to take into account hyperglycemia, hypertension, dyslipidemia, microalbuminuria, and antiplatelet treatment at the same time in order to reduce complications. And the STENO2 study is a very good example where we have seen that the multifactorial management reduced A1C, cholesterol, blood pressure, and triglycerides all significantly. And the target was reached best with a statin therapy for cholesterol and also the diastolic blood pressure target with antihypertensive drugs. Whereas glycated hemoglobin to go under 6.5 was difficult to reach, only 15% actually managed to get there. Now, these are the results regarding the microvascular complications, and you can appreciate that all nephropathy, retinopathy, neuropathy events were reduced by intensive therapy here on blue. And it was at 4 years already significant, and then there was a follow-up after 8 years, and the effect remained. And even after 13 years, when between 8 years and 13 years, no more intensified therapy was offered, but the patients were receiving whatever management they had, the effect remained. So it was very clear that there was a beneficial effect of the intensive therapy, also for mortality and cardiovascular events. After 4 years, mortality was not yet significantly different, but after 10 years, it started to appear, whereas cardiovascular events already after 4 years were significantly reduced. So very convincing evidence that the multifactorial management is working to prevent cardiovascular events in type 2 diabetes. And when it comes to these recommendations today, how to treat the very high and high risk patients with diabetes, now should be considered SGLT2 inhibitor or GLP-1 agonist in monotherapy, whereas low risk patients are using a metformin, and then there are stepwise increase in the medication, step 1, step 2, to continue like that. So the algorithm is quite clear how it is. And more about it you can find in this guideline in the European Society of Cardiology website. Thank you very much for your attention.
Very useful and practically very, very relevant discussion. And thank you very much, Dr. Jaakko, for joining us. So let us have a very brief question. So we have been discussing about the use of aspirin and the routine use of aspirin, and the recommendation is also to use the routine PPI. But there has been a recent recommendation to de-prescribe PPI due to the higher prevalence and the association with chronic kidney disease with proton pump inhibitors. So how can this go together?
You mean together with aspirin?
Yeah, with aspirin.
Yeah, so clearly this is an option for especially for the very high risk individuals, and naturally for the diabetic patients who already have cardiovascular disease, some sort of cardiovascular disease. So yes, this is also in the guideline is recommended to have a combination in a very high risk individuals. I didn't go to that, but yes.
You have dealt with very practically very relevant and probably a very controversial topic, the use of antihypertensives routinely in diabetes. Though we keep on discussing this, it is still remaining as a controversy and a topic of debate. So with the emergence of SGLT2 inhibitors, do you think or do you presume that the total dosages of antihypertensives will come down eventually?
Sorry, that was cut off. I didn't hear your question.
Jaakko, my question is, the SGLT2 inhibitors can also result in a subtle reduction in the blood pressure.
Mm-hmm.
So with the routine use, you have recommended routine use of SGLT2 inhibitors now in diabetes. So do you assume that the total dose of antihypertensives can get reduced with concomitant use of SGLT2 inhibitors?
Yes, I would say yes. With a full dose to try first, and then I personally would prefer to start using a combination therapy with a calcium channel blocker and RAS inhibitor to start with for every patient with diabetes. And that would be my personal choice. And it has been shown that especially in diabetic patients, to start with this combination is reducing cardiovascular events more than using other drugs.
Absolutely. It has got tremendous long-term benefits as well. So thank you very much, Dr. Jaakko. There are more than 8,500 doctors listening to us in the virtual platform. And a profound gratitude for joining us live.
All right. Yes. Thank you. Thank you.
Thank you very much, sir. Thank you.
Bye now.
Bye-bye. Over to my co-chairperson, Dr. Jahangir.
Yeah. Is there available Mr. Dr. Akhtar Hussain?
He is joining. I think he will be there. Dr. Benshibai can... next is Dr. Akhtar Hussain. So there is a... Akhtar Hussain? RX Events will be playing the video. So you can please introduce him.
Dr. Akhtar Hussain, he is President-elect of International Diabetes Federation, Professor in Global Health, Chronic Disease Diabetes, President Diabetes Asian Study Group, DSG 2018 to 2020, Vice President IDF 2013 to 2015 and 2016 and to 2017, member of the Finance Committee IDF 2016 to 2017, chair of the Consultative Section Science IDF, member and co-chair of the Bridges Committee IDF, member of Norwegian Diabetes Association, executive member Medical Board Norwegian Diabetic Association, life member of the Diabetic Association of Bangladesh, founder and life member Diabetes Association, Diabetes Asian Study Group, co-editor Journal of Diabetology, official journal of DSG, primary faculty member Nord University, Norway, faculty member Federal University of here, Faculty of Medicine, Fortaleza, Brazil, faculty member Center for Global Health, Bangladesh University of Health Science and Enterprise of the Bangladesh Diabetic Association, Dhaka, Bangladesh, former faculty member, University of Oslo, Norway, Faculty of Medicine, Department of International Health, 2002 to 2017. Dr. Akhtar Hussain is just presenting global perspective of diabetes, role of the IDF. Dr. Akhtar.
I'm Dr. Akhtar Hussain. I'm the President-elect of the International Diabetes Federation and a Professor of Diabetes and Metabolic Disorder at the Nord University in Norway. It's always a pleasure for me to talk in Diabetes India conference. I've been regularly invited, and thanks to the organizer for inviting me this year as well. I take it as a kind of big pleasure for me to talk in Indian conferences. As you know that I'm from Bangladesh, so India is very much home to me. So today, the talk of my today's presentation would be related to the global burden of diabetes and the role of the IDF, what IDF is doing. I'll be presenting some of the slides that you are quite familiar with. As you know that the diabetes trend is increasing, and it seems that there is no stop to this. And as you can see that we have about 1 in 10 people today. That means it's about 537 million people globally have diabetes. But this estimates actually do not take into account that we have about 1 in 2 adults remain undiagnosed. So 50% of the people remain undiagnosed. And we also know that this, for example, that impaired glucose tolerance rate, that the impaired glucose tolerance is about 441 million people. That is 1 in 9, every 9 people. So it's this situation that we see that is almost, it seems that this challenge is a kind of unmet challenge. And therefore, we need the global cooperation. We need the cooperation from all countries and all our member associations to fight this disease. Next one is, if you look at this, here I will try to draw the attention on, for example, on this GDM, that more pregnancies affected by hypertension, about 700,000. And this remains to be an underestimation that we all agree, because most of the people, most of the women are not diagnosed because many people still, the maternity care is outside the hospital setup. So this is a kind of grim picture I'm drawing to you, because it's not that I'm going to scare you, but it's just that how much initiative we need in order to have a discussion on this, or to have a kind of joint global collaboration to fight this condition. So the next one is if you see this number of people with diabetes, as you see that you have seen this IDF Atlas map, that it is increasing all over everywhere. And it seems that it is, but if you look at, for example, in our part of the globe, that is the South Asian, that's here you have Europe, here you have South Asia. We are expecting a kind of increase of 68% increase, compared to only 13% increase in Europe. So you see that in the European side, so we see that the increase in diabetes is much higher in poor and middle income countries. And this creates a kind of a much bigger challenge for our healthcare system to sustain this burden of diabetes. So in summary, if I want to say in summary that in 2021, the IDF 10th edition of the Atlas estimates that 1 in 10 people, that is 20 to 79 years of age, have diabetes. This equals to 537 million people, as I said. But this number by 2024, this number will increase to 784 million people. And there are still remain gaps in our estimations due to the absence of low quality data in some parts of the world. As you know that there are many parts of the world we actually struggle to get good quality data. There is a strong need for effective intervention strategies and policies to stall the increase of the number of people with developing the diabetes. So this is the grim picture that I'm drawing. And we also know that despite of all our medical and scientific innovations, we know that there are about 4.9 million deaths per year, which is related to diabetes. And it intersects with all dimensions of development. So the diabetes is now defined as not only a disease, but it's a kind of developmental issue. It costs about 11% of the worldwide health expenditure only for diabetes. So what are the major challenges that we see from the global arena, from the International Diabetes Federation? That we see that there is a rising trend of diabetes, as I have just described here, and we need a global action for this. And the other challenge is the inaccessibility of insulin to 50% of the people with diabetes, that 50% of the people diagnosed with diabetes who needs insulin have irregular or no supply of insulin to these people. And if you see this in sub-Saharan Africa, we see only 1 in 7 people in some parts of sub-Saharan Africa, that only 7 people with diabetes have access to insulin. We also see that there is a lack of global coordination between, for example, IDF, WHO, Ncds, that because we are providing different statistics, and this calls for a kind of more united work. And I will come to tell you that what we are doing to narrow these gaps. And corporate sponsorship, as you know, that finance to the organizations, finance to the work for people with diabetes is very much sponsored by many companies. And I will tell you that this is a big challenge, and also at a global level. And united voice for the people with diabetes. As you know, that the diabetes voice is being fragmented. And this is a big challenge to all that who are interested in diabetes work, that they should know that we should have one voice. I have nothing against any particular organizations who are also working on it globally, but we have to keep in mind that the organization that encompasses the whole world is International Diabetes Federation. This is the place this is your organization. It's nobody's organization, but many other organizations, you can go to Europe or to the United States. That's not your organization. You cannot be anybody in that organization. But tomorrow, you can be the president of the International Diabetes Federation. So you have to say that not your personal interest. I have nothing against that you are traveling around the world and attending conferences. They are also our member associations. So please do so. But you should remember that where is your home? You can travel around, but you must not forget that what is your home. And we also see that the policies that is being developed at a global level is not necessarily implemented at a national level. And we need to identify the barriers that why it is not implemented at a national level. Where is the gap? And then also that, as I said, that funding for non-communicable disease as a whole, not only diabetes, at a global level is far more challenging. And I will show you some of the statistics at the end. And I will appeal to all that please unite under one flag, that is the International Diabetes Federation, in order to meet the challenges that we have. If we fail today, we will be failed forever, because this problem is rising, and this problem is rising particularly in your door, in the poor and in the middle income countries. As you know, that India has the second largest population with diabetes. We cannot fail. We do not have any time to have any disagreement on this issue. Now I'm coming to International Diabetes Federation. What is International Diabetes Federation? Since 1950, this federation was established, and is associated with the United Nations Department of Public Information and in official relationship with the World Health Organization and the Pan American Health Organization. As you know, that IDF championed the UN resolution on diabetes, which is a major step. And because this was the first time that any non-communicable disease was recognized with an UN resolution on diabetes. So this was a major breakthrough and a big achievement for all people who are working for diabetes, not only for the International Diabetes Federation. Mission of the IDF, it is to be the leading and authoritative global voice for people with diabetes and those at risk for diabetes, and improve the quality of life of all people with diabetes, prevent type 2 diabetes, and fight discrimination against all affected by diabetes. Here, we should say that the IDF puts a particular emphasis on prevention. Because as we know that we do not know how to prevent type 1, but type 2, we know that is the effective measures. We can effectively actually prevent 60% of the people with diabetes. As we know that in poor countries, that when you have diabetes, then you have this disease for throughout your life. And this is a big challenge economically for many people in our part of the world, to meet the needs of the family and to buy the extra cost of insulin. So prevention is the only way out, particularly for our part of the world, and to promote diabetes care, prevention, and a cure worldwide. So what IDF does this we address these issues. We call the global voice of diabetes. And it is in partnership with sustainable and strong organizations of global at regional level, and policies at high quality research, policies, development, and also the presence that our visibility, the global recognized authority on diabetes. And I'll be going all these points in my next slides. So what is the vision of 2023? We are now in 2022. We need to think that we want to engage 1 million healthcare professionals by December 2023 for the work of diabetes. And this is also one of the things that I think countries like India should have a particular role to play, because we know that we have, is a big country with this a big health infrastructure that you have in place. That help from the Indian diabetes organizations is essential to achieve this milestone. And we are coming in, we started, as you know, that we started this IDF in 2019 when I was elected. We have challenging this 2021 and 2020 up to 2022 because of the COVID era. That was, as you know, there is no secret that the Busan conference was not a success for the IDF. We have neither got a visibility nor any financial benefit from this conference. We are working on the IDF School of Diabetes. We have to admit that this school was the vision of late Dr. Shaukat Sadikot, and we recognize. And today I'm the chair of this IDF School of Diabetes. I will come more closer to it. I will describe more of this school later. IDF, the conferences that we will have in December, I hope that you all can participate in this conference that is coming in. And as you know, the best of the IDF, that is, we are also creating the kind of best of IDF, and many of your organizations are already enlisted there. So what do? We do evidence-based research. We are involving in policy and advocacy, campaign and communication, education and training, and World Diabetes Congress and events. These are the major events that we are saying. But under this, I will show you, I'll touch some of these issues that how we are accomplishing this task. As you know that this IDF Atlas, as the world recognizes that this is the authoritative voice. Most of the people in the science or in the administration, actually they rely on the IDF Atlas. We are narrowing our discussion with the WHO that WHO produces some data at times, and they also recognized that IDF Atlas is the most authoritative voice for in this regard. So we are trying to come close, and hopefully that in near future we'll have IDF WHO Atlas. And we are working strongly because the differences that we see in terms of statistics is not a major difference. There are some small differences because the data that we are collecting is collecting from two different sources. In the countries where we do not have the national data, where we rely on self-reported data. WHO doesn't do it. On the other hand, WHO collects data from health facilities, and which is a facility-based, and we do not collect from the facility-based because we think this is a kind of can be skewed data because it's not that all the people are coming to these facilities. But these are the issues that we are discussing, and we can see that how we can make it more even, so that we can have only one statistic, so that people are not confused on these issues. As you know, that the World Diabetes Day that we have started, actually that the World Diabetes Day is started from 1991 together with the IDF and the World Health Organization. And the day was decided on November 14th in response to the rapid rise of diabetes around the world and recognition with the birthday of Sir Frederick Banting. As you know, we all know about Banting. We do not have to mention anything more. In 2007, in the General Assembly, adopted resolution of 61 and 225 designed attaining 14th November as the World Diabetes Day. I think that we all should take pride that despite of our weaknesses, that the big countries, the rich countries, refuse to put this resolution on the UN desk. At that time, Professor Martin Schilling was the president of the IDF. He traveled around from his country to Australia to all major countries. But finally, Bangladesh, the poor country, agreed to put this motion forward in UN, and where we got this resolution. So we see that even a small country can make a difference. So 3-year at 3, access to diabetes care is if not now, and then when? So the year 1, we want to focus on access to medicine and care. Year 2, I would like to focus on access to education, health professions, people living with diabetes. It is also important for patient education. Year 3, primary and secondary prevention. So these are the main focuses that we are doing on the World Diabetes Day. We also want to increase the global awareness of diabetes, as I've said, that insulin at 100 years. The 100 years we have been using insulin for human treatment. What happened in this time? That you see that the century of insulin presents an opportunity to raise awareness of diabetes to an unprecedented level. The development of the therapeutic insulin in 1991 was a landmark breakthrough in the history of medicine. And then questions that what we have achieved. As we said, that 50% of the people remain without access to insulin, who needs the insulin. Parts of sub-Saharan Africa, only 1 of 7 people. Is it that we can be proud of? We have a kind of shared responsibility of the local governments and the companies. With this shared responsibility, we must bring together for the betterment of humankind. With this mission, that IDF took a lead to create a WHO resolution with the support of all international partners for universal access to insulin. We had lots of difficulties, I must say, that actually the big countries, the strong countries, they actually were not in support because they were afraid that their countries are producing insulin and their market, the companies from these countries will be affected. Even though we try to give an assurance that IDF has nothing to do against any companies. We need insulin. It's not that we don't need insulin. What we need a resolution that all countries, all the governments are bounded to secure the access to insulin together, as I said, together with our partners in the industry, because we have a kind of shared responsibility. However, the resolution was passed on 27th May 2021 under the name Resolution on Reducing the Burden of Non-Communicable Diseases through Strengthening Prevention and Control of Diabetes. So it is not that what we actually wanted. It was a little bit changed, but we think that at least that we have one resolution that which we can build on. And this one you can find on IDF's reaction to the resolution and its adoption in the IDF's news article on this issue. So we are strongly working together with our international partners to create this movement. And that's providing access to life-sustaining medications and monitoring. So we are also partnering with direct relief in case of any kind of catastrophe, as we are saying now, Ukraine. Sometimes ago, we have seen it for example, in Gaza, in Palestine. So we see that these things are breaking up at different times. So IDF does what we can do. Even in COVID time, we try to secure the supply of insulin with some partners like direct relief. And advocating globally for people with diabetes and those at risk. So it's a kind of advocacy work that is promoting change in diabetes and the implementation of advocacy campaigns. So we are creating some kind of advocacy body so that people are trained to say that how they can do on this particular area through regional webinars, policy briefs, outreach member states, participation to high-level meetings, collaborating with the WHO and PAO, strategic alliance with the NCD Alliance, medicine, patent pool, and global coalition for circulatory health, etc. And we also are empowering people who live with diabetes, as you are familiar with Blue Circle Voices and the young leaders in diabetes. And network is focused on ensuring that the voices of the people living with diabetes, together with their carriers and family members, are prominently heard and their concerns and priorities are taken into account. And we also created an advocacy academy. This will also give us the training of these young people for diabetes facts, project development, relevant advocacy, public speaking, and storytelling, and use of social media. So coming back to the international collaborations, what we are doing at this stage, that the WHO, as you know, that we have a diabetes compact in the WHO. And this gives us a kind of great opportunity to have closer ties with WHO. In diabetes medications, in the essential medicine list, we are enlisting some of the medications that I will come back to this. That they should be taking as a kind of essential medical, include them in the essential medicines list. In 2021 resolution on reducing the burden of NCDs through the prevention of diabetes, as you say, that we have got this resolution. Insulin pre-qualification programs that we want to create. And we want to set a target that there will be a kind of WHO conference WHO World Health Assembly on 22nd of May this year. So where we want to have that IDF recommendations that 100% diagnosis of young people with type 1 diabetes should be secured, and manpower development through IDF school program. We are also collaborating very closely with the WHO. And in this, as I said, that with this WHO, that IDF and the medicine patent pool welcomes the inclusion of SGL2 inhibitors to the WHO's essential medical list, which we have secured. As you know, that during this pandemic time, that the diabetes research and clinical practice, we have issued 2 special supplement on this particular issue, diabetes and COVID-19, the IDF perspective. So this was co-edited by me and Antonio Cerullia. And on this occasion, the diabetes research and clinical also takes this opportunity to mark the 100 years of experience with insulin. So we also have a special issue on Antonio and myself, as I know that many of you from India have participated in both of these special issues. Now we are talking about this education that we have. At the moment, we have about, actually, it's not 70, actually, we have passed now 72,000. We are around 73,000 healthcare personnel registered. The time that I took over the office, then it was about 45,000. So we are now 73,000. So we have made a significant progress in terms of the IDF school registrations. And at the moment, we have more than 110 territories is engaged in the IDF school. And it's a rural reach is about 70 17%, but we see that most of the countries that who are collaborating with us is low and middle income countries, and which we are very happy about, because it's our mission is to provide the education to the people with diabetes. And we know that rich countries have their own schools. So I think that the low and middle income countries are getting this opportunity or taking the advantage of this IDF school is a very good news. So we also have some kind of free courses, and we also have some premium courses. It's up to people. So you can have a lot of information from this school, which is without any cost. So what is the future? That the way I'm thinking? I'm thinking that there are three ways that we should develop this school. At the moment, we are working only on a global level, but our regions are very different. And therefore, we have to tailor our programs at a regional level. And for this, we need the cooperation of every region. So that means that the global program must be tailored, but this we cannot do it from the IDF without the cooperation from the region. And that's, but up to the national level would be difficult at this stage. So I think that I will try to take it down to regional level. And then third is the complementary. Many of our member associations has already some kind of schools that you are training your people in the field of diabetes. And then we are not competing. We'll complement. We'll say that if the need or support, we'll say that how we can complement to the ongoing program. So that is the thing. We will not compete. We will not weaken our member association. We will strengthen our member associations. So, and then what are the next things that I will be saying? The revisiting the IDF guidelines for type 2 diabetes, GDM, and others. This is that the work I have started my mental mapping so that I can take over this work at the very within this year. IDF will take a new initiative to revisit and update the guidelines in the light of new evidence and discoveries, which we need to do, because the last guidelines that we had one in 2012, one in 2017, which was Shaukat and they did, but that was mainly focused on the primary healthcare. So we'll have to develop, revisit, and we'll have to develop this guideline. And type 2 diabetes, GDM, and fasting. As you know, that type 2 diabetes is GDM. We do not have it. We need to create, because there is no international agreement either for the diagnosis or for the treatment of GDM. And as you know, that fasting and Ramadan, as I believe that people of all faiths have some kind of practice of fasting. IDF includes people of all faiths. So we cannot have Ramadan and diabetes. We will have fasting and diabetes. And for this reason, I have seen the guidelines that we have. There are many good things, but there are things that needs to be developed, because every time this was developed, probably it was not properly scientifically valid documents. So we need to develop it so that the recommendations that we make, it becomes a scientifically valid document. The committee will be set up this year, then in 2022, and will complete before I leave my presidency by 2024. IDF is also expanding in China. We have entered, so we have created this IDF school in Chinese, and this is actually a very fast expanding area that you should know about. We are also making a number of webinars. For example, these are the two webinars that we have done: managing CVD and renal risk in type 2 diabetes beyond glycemic control. And as many of you know, Professor Kunti from here, and also Professor Nabi Sattar from UK, and also Professor Henry Group. And then we also have this evolving landscape in the management of type 2 diabetes. So we are creating, and these webinars are free of cost. Anybody can join, and I will urge all of you to come and join this. And last one, my request to you that IDF Congress that it is without you, there is no Congress. So it is your responsibility to make the IDF Congress is your Congress, to make your Congress visible success. India, we expect a lot from India, because India is a big country. and it has contributed a lot to the for IDF and for the diabetes.
Yeah, Jyoti.
Hello, thank you. So that's the end of the Scandinavian Symposium, and that has been very, very contributory and aligning with the theme of our Diabetes India 2022 Insulin Discovery 100 Years. Over to Dr. Jahangir to conclude.
Oh, thank you, Dr. Keshavadhan. It was a nice session, really. Particularly last speaker, he has raised the problems and difficulties and challenge of diabetes, the raging tendency of diabetes mellitus, and particularly we should raise our united voice for the people with the diabetes mellitus. And that is the main message and vision. I am giving thanks to all the speakers and my co-chairperson, and also the Diabetes India. Again, hoping we will meet together. I am just concluding the session. Thank you, everybody.
Thank you. Thank you, Dr. Jahangir, Dr. Jyoti Dev.